Welcome to the Smart OB-Med curriculum. Social media for advancing residency training in obstetric medicine. We here present to you a national collaboration between the Universities of Ottawa and Alberta. This research project has been generously funded by the Department of Medicine at the Montfort Hospital, empowering future physicians in the care of medically complex pregnancies. We hope you will enjoy it. This module will cover gestational diabetes, or GDM, as well as pre-existing diabetes in patients who are considering pregnancy or have become pregnant. All types of diabetes can lead to complications during pregnancy, from type 1 and type 2 diabetes to other less common types, such as MODY, or maturity onset diabetes of the young, LADA, latent autoimmune diabetes in adults, or steroid-induced diabetes. To reduce complications, it is imperative to screen for diabetes preconception in those at higher risk and to look for gestational diabetes during pregnancy in those without known diabetes or prediabetes. A quick review of very different diagnostic criteria of pregestational versus gestational diabetes. Diabetes is diagnosed with fasting glucose of 7 or higher, A1C of 6.5% or higher, or 75-gram oral glucose tolerance test with 2-hour value of 11.1 or higher. Prediabetes is diagnosed with either an A1C between 6 and 6.4%, impaired fasting glucose of 6.1 to 6.9, or impaired glucose tolerance with 75-gram 2-hour value between 7.8 and 11. Universal screening for all patients who are not already pre-diabetic or diabetic is recommended. The Canadian Diabetes Association guidelines recommends the preferred approach for GDM screening, whereby women have a glucose challenge initially with a 50-gram challenge, followed by a 75-gram tolerance test if necessary. The 75-gram tolerance test is required if the 50-gram 1-hour value falls between 7.8 and 11. If the value is 11.1 or higher, GDM is diagnosed. If the 75-gram tolerance test finds a fasting of 5.3 or higher, a 1-hour value of 10.6 or higher, or a 2-hour value of 9.0 or higher, then the GDM diagnosis is made. Only one value needs to reach these thresholds for the diagnosis of GDM to be made. Normal gestational glycemia is generally much lower than the thresholds for diabetes control in pregnancy recommended by guidelines. For example, while the normal fasting glucose may be around 3.9 in a patient without pre-existing diabetes or GDM, the guidelines suggest to aim for fasting glucose below 5.3 in this population. This is similar in the postprandial values of women without diabetes, as they have postprandial values that are generally much lower than the thresholds recommended by the guidelines. We will first focus on gestational diabetes or GDM, which is the most common medical complication in pregnancy. GDM is a state of carbohydrate intolerance, and most patients who develop this condition during pregnancy have risk factors for type 2 diabetes. A diagnosis of GDM is an important risk factor for developing type 2 diabetes later in life. When untreated, GDM can lead to serious maternal and fetal complications, with increased risk of preeclampsia, as well as increased fetal growth velocity leading to macrosomia, birth injury, higher chances of cesarean section, as well as an increased risk of neonatal hypoglycemia, and higher rates of neonatal intensive care unit admission for various reasons, including respiratory distress syndrome in the newborn. Obstetricians may often plan for induction of delivery for patients with GDM. We saw the preferred approach the Canadian Diabetes Association recommends, but there is also the alternate approach. As seen, the preferred approach recommends starting with the 50-gram challenge test and continuing with the 75-gram tolerance test if needed. The alternate approach goes straight to the 75-gram tolerance test and has different and lower cutoffs for diagnosis of GDM. The alternate approach is used in international guidelines. However, due to its stricter criteria, it leads to more than double the cases of GDM diagnoses, with 16.1% of patients diagnosed as opposed to 7% using the preferred approach. When these two approaches were compared in a 2022 NEJM randomized trial, the two approaches have not led to different outcomes, confirming that the Canadian Diabetes Association preferred approach is clinically appropriate. If not screened for type 2 diabetes prior to pregnancy, women with risk factors for type 2 diabetes can be screened in early pregnancy. However, the glucose challenge and tolerance tests are not validated outside the 24 to 28 week gestation window, and the guidelines on screening for early GDM are vague. Studies show that an A1C of 5.9% or higher in the first trimester often predicts earlier rises in glucose and earlier onset of GDM. Despite the varied practice in Canada in diagnosing and treating early GDM, it is reassuring that there is no strong evidence that earlier management is much better. The Toboggan 2023 trial compared pregnant patients treated early for early onset gestational diabetes to those initiating treatment after 24 weeks gestation, showing only modest improvements in neonatal adverse composite outcome. The goal of management of GDM is to achieve tight glucose control, as this is associated with improved maternal and fetal outcomes. Generally, experts recommend to target a fasting glucose of less than 5.3 and a 1-hour value post-meal of less than 7.8 and a value of less than 6.7 2 hours postprandially. Management of GDM requires a holistic approach including both non-pharmacological and pharmacological therapies. More specifically, adequate glycemic control may be achieved with dietary modifications, exercise, and appropriate weight gain during pregnancy. The pregnancy diabetes clinics are staffed with physicians as well as skilled dietitians and diabetes nurse educators or specialists. In cases where targets are not met with non-pharmacological methods, insulin is typically considered first line for pharmacological therapy. It has been the mainstay of medical management of GDM for many years and has a long record of safety. Although there is risk of maternal hypoglycemia, insulin does not cross the placenta, making it very safe for the fetus. There is no maximum dose, and regimens can be adjusted until targets are met, from long-lasting insulin to mealtime short-acting insulin. Other inconveniences of insulin therapy include the use of needles, potential need for multiple daily injections, and increased gestational weight gain. Oral agents are less commonly used and may not prevent the need for insulin use. Metformin is the most frequently used oral agent, either alone or concomitantly with insulin. However, metformin does cross the placenta and long-term outcomes are unclear, although medium-term outcomes are reassuring. When metformin is used in GDM as a first line, it is expected that 40% of the patients will need additional treatment with insulin. Glyburide can rarely be used, but it is inferior to insulin and leads to more macrosomia, neonatal hypoglycemia, and maternal weight gain. To improve maternal and fetal outcomes during pregnancy, gestational weight gain recommendations should be followed. The recommended range of gestational weight gain depends on maternal pre-gestational body mass index, or BMI. For a woman entering pregnancy with a normal BMI, gestational weight gain of 11.3 to 15.9 kilograms is recommended, which is 25 to 35 pounds. But when BMI is above 30, healthy gestational weight gain should be restricted to a lower range of 5 to 9.1 kilograms or 11 to 20 pounds. Care for patients with GDM goes beyond pregnancy and well into the postpartum period. GDM significantly increases the risk of developing type 2 diabetes, up to 12 times the risk of patients without a history of GDM. This translates to an approximate risk of 20% at 10 years after a diagnosis of GDM. This risk is even higher for patients with gestational hypertension or preeclampsia. Therefore, it is essential to screen patients for type 2 diabetes after delivery, ideally with a 75-gram oral glucose tolerance test 6 weeks to 6 months postpartum. However, given the poor uptake of oral glucose tolerance tests postpartum, the UK NICE guidelines suggest fasting glucose and A1C as alternatives. Although these are less sensitive, in some cases of diabetes and prediabetes will be missed. A diagnosis of GDM is also a good opportunity to counsel patients on ways to prevent recurrence of GDM in future pregnancies or reduce their risk factors for future type 2 diabetes. This includes weight management, exercise, healthy diet, and smoking cessation. Breastfeeding has also been associated with reduced progression to type 2 diabetes in the mother and reduced obesity in the offspring. Now, let's move on to pre-existing diabetes in pregnancy. The prevalence of this comorbidity in pregnant patients is increasing, driven by the rise in prevalence of type 2 diabetes in the general population. The risk of maternal and fetal complications is also significantly increased in these patients, and although maternal and fetal risks go down with appropriate glycemic control, the risks nonetheless remain higher than in the non-diabetic population. In pregnant patients with pre-existing diabetes, there is a 40 to 45% risk of gestational hypertension and preeclampsia. In fact, these patients should be offered interventions for preeclampsia prevention. There is also an increased risk of miscarriage and preterm delivery, as well as higher rates of C-section, large for gestational age fetus or LGA, and conversely, although uncommon, an increased risk of IUGR or intrauterine growth restriction. Fetal risks include congenital anomalies, neonatal hypoglycemia, respiratory distress syndrome, and jaundice. The risk of stillbirth is also higher, with a live birth rate in pre-existing diabetes of 98.8% versus 99.6% in non-diabetic patients. Maternal risks are also worsened if micro or macrovascular complications of diabetes are present. Pregnancy can also worsen these complications. In terms of kidney disease, proteinuria will increase in pregnancy, regardless of pre-existing diabetic nephropathy. In pregnancy, urine ACR or albumin creatinine ratio threshold is less than 8 milligrams per millimole, and urine protein to creatinine ratio or urine PCR is less than 30 milligrams per millimole. Pre-existing proteinuric nephropathy increases the risk of preeclampsia, but can make diagnosis challenging. If pre-pregnancy eGFR is less than 60, preeclampsia risk is even higher, and there is also possibility of further permanent renal decline in these patients. Retinopathy can develop and worsen in the first part of pregnancy and with fast glycemic control, especially if it was present prior to conception. The risk persists up to 1 year postpartum. Therefore, a retinal exam is recommended in the first trimester and within 1 year postpartum, and with any change in symptoms during pregnancy. Of note, laser photocoagulation for severe retinopathy preconception reduces the risk of visual impairment. When indicated, this can also be done during pregnancy. The risk of macrovascular complications is also higher, but thankfully remains rare. Preconception counseling is critical for patients with poorly controlled diabetes. If glycemic control is improved, both maternal and fetal outcomes are better. Hyperglycemia is teratogenic, and poor glycemic control in the first few weeks following conception increases risk of congenital anomalies. Overall risk of congenital anomalies is somewhere between 3 and 5% in the general population, but this is reduced to 1.8% with good preconception care. Preconception A1C target should be less than 7%, but ideally less than 6.5% if this can be safely achieved. Generally, it is easier to achieve such tight control with type 2 diabetes, but less so with type 1 diabetes due to the large swings into the hypoglycemic range. This graph illustrates that hyperglycemia is teratogenic. We can see that a rise in A1C is associated with increased risk of congenital anomalies. an A1C of 14% is equivalent to exposure to oral retinoic acid, which is a well-known teratogen with approximately 20% risk of congenital anomalies. It is also important to closely monitor glycemia during the entire pregnancy, both fasting and postprandial. Using a continuous glucose monitor system can be helpful. Good glucose monitoring and control can improve outcomes. For example, in type 1 diabetes, continuous glucose monitoring was found to reduce LGA, neonatal hypoglycemia, and NICU admissions. Glucose levels vary quite significantly throughout pregnancy, especially for patients on preconception insulin. In the first trimester and up to 8 weeks of gestation, levels will be quite labile and the risk of DKA is higher in patients with type 1 diabetes. Then, up to 16 weeks of gestation, there is increased insulin sensitivity leading to higher risk of hypoglycemia, after which, at 16 weeks onwards, there is gradual increase in insulin resistance. This usually plateaus around 36 weeks gestation, with occasional slight improvement in insulin sensitivity in the few weeks preceding delivery. Postpartum insulin resistance drops, and in some patients with type 1 diabetes, a transient insulin holiday can occur. Some considerations in patients with pre-existing diabetes include the need for use of multiple daily injections or an insulin pump in order to achieve glycemic targets. Frequent testing 4 times per day or more, or ideally using continuous glucose monitor, can help achieve these goals. Of note, the CONCEPT trial, a reduction of neonatal risks was seen when patients with type 1 diabetes used a continuous glucose monitor as opposed to glucometer testing only. In addition, the newer trial on metformin called Metformin in Women with Type 2 Diabetes, or MIGHTY trial, looked at adding on metformin to insulin and showed reduced maternal gestational weight gain and less LGA, but more SGA, shifting the curve towards smaller fetuses. Although the subsequent MIGHTY Kids follow-up on kids exposed to metformin in utero is overall reassuring, longer-term results are currently lacking. There may be some metabolic effect of this exposure that is still unclear. The conclusion of this landmark trial is that the mainstay treatment remains insulin, and metformin can be considered as an add-on. The fetus should be closely monitored as well in the context of diabetes and pregnancy. Starting at 28 weeks, fetal growth should be assessed every 3 to 4 weeks. After 36 weeks of gestation, the frequency may be increased to weekly until delivery, depending on the clinical context. During delivery, glucose levels less than 7.0 should be targeted to reduce the risks of neonatal hypoglycemia. Intravenous insulin and glucose infusions may be needed to achieve this, especially in patients with type 1 diabetes. After delivery, insulin resistance decreases sharply, resulting in a quick drop in insulin requirements. It is important to appropriately down-titrate insulin regimens to avoid causing hypoglycemia. Some patients with type 1 diabetes even experience a transient insulin holiday. With this in mind, patients with preconception insulin should have their postpartum insulin doses down-titrated to 50 to 70% of their pre-pregnancy amount after delivery. Insulin requirements typically return to pre-pregnancy dosing around 6 to 8 weeks postpartum, but this period can sometimes be prolonged if the patient is breastfeeding. It is therefore important to warn of increased risk of hypoglycemia, particularly with nocturnal nursing. Breastfeeding has been associated with lower rates of subsequent development of diabetes. It is also important to note that women with pre-existing diabetes generally have delayed milk production and are more likely to stop breastfeeding. However, once supply is established, lactation persists for similar durations to non-diabetic mothers. It is therefore important for these women to access timely lactation support with a lactation consultant. In our type 1 diabetes population, screening for postpartum thyroiditis with a TSH around 3 months postpartum is recommended, given the increased incidence of postpartum thyroiditis in this population. It is important to note that postpartum, both metformin and glyburide can be safely used when breastfeeding or pumping milk. In addition, taking the opportunity postpartum to counsel about future pregnancy planning and contraception is recommended. We thank you for watching our Smart OB Med Foundation series, Diabetes module. We hope you've enjoyed it.